Hello. I'm excited to share the highlights of our recent publication in the Journal of the American College of Surgeons, evaluating the associations of social vulnerability with receipt of guideline-concordant care among patients with colorectal cancer. Evidence-based guideline-concordant care has been associated with improved survival for patients with colorectal cancer. However, the effect of community-level factors on its receipt have not been well examined. We queried the National Program of Cancer Registries database to identify patients with colon and rectal cancer. Data were then linked to the 2020 CDC Social Vulnerability Index at the county level. The SVI ranks counties on themes related to socioeconomic status, household characteristics, racial and ethnic minority status, and housing type and transportation. The overall SVI score ranges from 0 to 100, with 100 indicating the most vulnerable population. The primary outcome of the study was receipt of stage-specific guideline-concordant care for colon and rectal cancer, including lymphadenectomy and receipt of neoadjuvant or adjuvant therapies. A total of 125,000 patients were included in the study, with 82% having colon cancer and 18% having rectal cancer. The median SVI for the cohort was 60.9. A higher proportion of patients with high vulnerability were non-white and were uninsured. Over 70% of patients from both the high and low vulnerability groups were treated at Commission on Cancer accredited hospitals. Compared to patients with low vulnerability, patients with high vulnerability had lower odds of receiving guideline-concordant care. Those treated at COC accredited hospitals had a 79% increase in odds of receiving guideline-concordant care. Additionally, there was a decreasing association between SVI and the probability of receiving guideline-concordant care. Notably, this probability among patients treated at non-COC accredited hospitals declined faster than among those treated at COC accredited hospitals. The receipt of guideline-concordant care was associated with a decreased mortality risk for both SVI groups. However, after adjustment, highly vulnerable patients treated at COC accredited hospitals had a decreased mortality risk. These findings may reflect COC requirements for adherence to treatment guidelines, community engagement, and addressing barriers to care. Further work is required to investigate the components of hospital accreditation that improve the receipt of high-quality guideline-concordant care and outcomes for underserved populations.